with a normal PSA? Anyone? What percentage of the prostate cancer people come with the normal PSA? PSA less than 4.
27%.
Yeah, very good. 25% of prostate cancer, or else if a PSA less than 4, or prostate cancer cohort, if you take 25% patient can have a normal PSA. That again, that study, that is from the same study. PCPD trials once said that PSA even less than 4, there's a 25% risk of prostate cancer. But I don't know whether that is absolutely correct, but they might ask this.
And the other thing is PCPD trial is an extension of PLUS trial. I think it is the use of finasteride for prevention of acute urinary retention and the need of surgery for male lobe tract symptoms. Because PLUS trial is 4-year follow-up, and then PCPT is extended, same trial extended with the name of PCPT. And then they quoted a sentence like putting the results in perspective. They say, I mean, the greater risk of developing high-grade cancer while taking finasteride did not increase mortality. On the other hand, conversely, the greater chance of preventing a low-grade cancer while taking a finasteride did not reduce mortality. So either way, it is the same. So because of that, FDA did not approve finasteride for prevention of prostate cancer. Am I correct?
I think the FDA recommends that the patient should be informed if you are going to prescribe finasteride. That there are literature which there is a slight increased risk of having a high-grade prostate cancer, but that has to be sort of informed at the time of prescription. And the other thing is there are counter arguments also. I think, I don't know whether I missed that part, whether you have discussed about the size of the prostate. The high-grade cancer is actually related to the size shrinkage by the finasteride, which will give rise a bit of a relatively high volume disease when you compare them with a patient who's not in finasteride. And there's another counter argument which says there is a overall ISUP grading change during the sort of last 10-30 years. And then because of this ISUP grade change, apparently, which was sort of not so high grade earlier, would have been now categorized as high grade because of the ISUP change. So those are two counter arguments, which is sort of against the so-called high-grade prostate cancer with finasteride prescription or as a prevention. I think that is of interest of note.
Yeah, another thing they can ask, what is the pharmacology difference between finasteride and dutasteride? What is the difference?
Finasteride, the class 1 and type 1 and type 2 receptors. The finasteride is type 1 receptors.
Yeah, where is the finasteride acting?
It's acting on the 5-alpha reductase.
Reductase, 5-alpha reductase enzyme. So there are two isoenzymes, type 1 and type 2. So basically, dutasteride inhibit both isoenzyme. Finasteride inhibit only one, I think type 2 or something. So this have a more reduction in intraprostatic dihydrotestosterone level, dutasteride, than the finasteride. But clinical benefit is not justified. No, more or less same. Even though pharmacologically dutasteride is more potent than the finasteride, but clinically up to now the research have not proved any difference between the finasteride and dutasteride. There are more different in the pharmacokinetic and dynamics, but I can remember only this term.
In the 5-alpha reductase, one is found elsewhere in the body, whereas
Yeah.
Type 2.
2 is exclusive for the prostate.
So when we discuss this study, ultimately, we can say during the 2003 trial, the finasteride is not recommended because of the high risk development of high risk prostate cancer there. But the publication on 2018, they are recommending finasteride. That's sort of thing we can say.
Yeah. When you say things the examiner don't know, or maybe a controversy things, they will be happy sometime. I don't know. Another sir?
Yeah. Yeah. Must be, yes, yes. Now you can say yes. You can't say there is a recommendation as such, Hillary, but we can say the trial shows that it reduces,
Right. Okay, sir.
isn't it? I think there may not be enough this thing because you see where the problem is if you give finasteride in thinking now when you are giving it as a therapeutic drug and you are getting this advantage, that is okay. But if you are going to recommend it as a preventive tablet, for people who do not have symptoms, who do not have any other advantage of it, it will be a little risky thing, isn't it? Because of the side effects. Then these patients will refer the first study in the internet and will come and ask whether will it increase the high grade number. So all these things can be there. So since you know everything, you can tell all the findings rather than making it as a recommendation as such.
Okay.
I don't know. That's how I would look at it.
Yeah.
Rather than just making a sort of a conclusive thing.
Yeah, just to remind the side effects, erectile dysfunction in 8%, increased libido in 6.4%, and ejaculatory dysfunction in less than 1%. So that also has to be brought to the discussion if you're
Yeah,
about that.
exactly. There was a theory that it might cause depression or something, Nishant, but it's not substantiated, no?
Not as I haven't heard that.
Okay, there was one paper and that was disproved subsequently.
Yeah. And do you know any other usage of finasteride? It's commonly used in other countries, not in our country.
Hair loss
Hair loss, yeah, male hair loss.
prevention. So.
Same dose, we can't use same dose. No? So 1 milligram.
Yes.
Okay.
It's available here also. Shall we move on to the third presentation? It will be by Dr. Munipriya Villararchi. He will speak on the precision trial. Over to you, Muni.
Can you see the screen, sir?
Not yet, Muni.
Share the presentation.
Yeah, you can't see the presentation.
The screen sharing has failed to start. Try it. I don't know why. I will.
You can see your picture.
Yeah. Sorry for the
Okay.
inconvenience. I will share my screen. So, sorry, sir.
No problem, Muni. We can see.
This is a study of precision trial. This is a multi-center trial. Study is designed in a 20 non-inferiority trial. So, can someone help me? I will share my presentation. So somebody can share it through the Zoom.
Muni, if you can put it to the WhatsApp group, then I'll share it from my computer.
Yes. Yes, please.
Can you send it, Muni?
So if possible, if we can move to the other presenter while
Yes.
Muni is getting ready,
Yes.
sir.
Yeah,
that's a
we'll
good
do,
idea.
yeah,
Yeah.
we'll do like that. Muni, you can come online slowly. Until then, I will invite Dr. Sasikumar to make his presentation on radical prostatectomy versus observation in early prostate cancer. Over to you, Sasi.
I think you can
Yes.
see the screen,
We
right?
can hear now. Yeah, we
Yeah.
can see the screen.
Right. So it's about the SPECT4 trial, that is a Scandinavian prostate cancer group study number 4. And the trial is mainly talking about the early prostate cancer and the treatment modalities here, radical prostatectomy versus watchful waiting, not the active surveillance here, it's a watchful waiting. So the trial actually started in 1989 and concluded in 1999. And it's done in Scandinavian countries, including Finland, Iceland, and Sweden, and sponsored by Swedish Cancer Foundation, which involved 14 centers. Here, the number of patients here is 698 men, and all less than 75 years of age, and who had newly diagnosed. And here I mentioned it's clinically detected prostate cancer because at the time, rather than a PSA detected prostate cancer, it's a clinically detected prostate cancer. So the people are divided between 2 groups in a randomized controlled trial manner. And the inclusion criteria include the localized prostate cancer with no bone scan negative. And the grade 1 to grade 2, that means highly to moderately highly differentiated tumors are included, and the PSA level less than 50. So the people less than 10 years of life expectancy and other cancer types were excluded from this trial. So they published their initial publication in New England Journal of Medicine in 2002 after a follow-up period of 6.2 years of follow-up. And then they said the radical prostatectomy significantly reduced the disease-specific mortality. At that point, they only conclude disease-specific mortality. And they said there is no significant difference between the surgery and watchful waiting on overall survival. Again, the same group, they published their article in New England Journal of Medicine in 2005 after a median follow-up of 8.2 years of follow-up. Then they find the same finding. That means there is a disease-specific mortality at that time of follow-up. And in addition to that, they find some overall cancer mortality, and the reduction in risk of metastasis and local progression. But they said there is a small risk reduction in the metastasis and the tumor progression. Then again in 2008, they published their finding in journal, and in after a follow-up period of 10.8 years, and they said come out with the same finding. That means there is a reduction in cancer-specific mortality, and sorry, and this is the final article in 2018 after a median follow-up of 23.6 years. The article published in New England Journal of Medicine in 2018. So here they found there is a prostate cancer specific mortality of around 12%, and that is after 23 years of follow-up, mean follow-up of 23 years. So the finding were the patient in radical prostatectomy group gain a mean 2.9 extra years of life compared with those of watchful waiting. That is, after a long period of follow-up, they find only 2.9 extra years of life. So the conclusion is radical prostatectomy reduced the all-cause prostate cancer mortality compared with watchful waiting at the median follow-up, at the mean follow-up of 23 years. So as a take-home message, this is saying that radical prostatectomy is having a reduction in cancer-specific mortality in a long term. But here, considering here, it's mainly the cancer group included were clinically detected prostate cancer rather than the PSA detected prostate cancer. Over a period of time, our cancer diagnosis, the screening methods changed a lot. The study started in 1989. So I don't know whether it's applicable at this point. That means whether it will give the same beneficial effect for the currently detected prostate cancer. And in addition to that, compared to the risk reduction over a period of time, it's very low. And it takes long time to get the particular beneficial effect. So considering that, we have to decide on whether aggressive treatment for prostate cancer, particularly arrested cancer, beneficial in this regard. Sometimes we may misguide by this trial in the current era. So we have to select the patient depending on their life expectancy and the aggressiveness of the grading of the disease, rather than go by this trial. Thank you.
Thank you, Sasi. Any comments?
So I think we have to somehow read about the PROTECT trial also somewhere, because that is the
What you are telling, no?
Yeah. And anyone discussing about pivot trial, PIVOT pivot trial?
Not today, Gobi.
Okay,
Yeah,
sir.
it's
Again, that will come somewhere. I think pivot trial says prostate cancer intervention versus observational trial. They have concluded that men who have less than 15 years of life expectancy unlikely to benefit by the cancer intervention. So that is a pivot trial. That is one thing. And anyone discussing about BOLAR trial, BOLLAR, BOLAR trial?
Not
It will-
today.
Again, that is prostate cancer and radiotherapy that we use in our guidelines. If after prostate surgery, if someone have positive margin, giving radiotherapy, adjuvant radiotherapy increase the overall survival. That's one finding of BOLA trial. Of course, we do that. Second thing is radiotherapy more effective when combined with hormone treatment for locally advanced prostate cancer. Again, that is in the guideline. That is from the BOLA trial. So BOLA trial is again important for after positive margin, giving radiotherapy improve the overall survival. And for a locally advanced cancer, when you are giving radiotherapy, better to give a ADT and reduce the prostate size and then give the radiotherapy. So that's again from that same trial. So whenever you mention that, we have to mention the BOLA trial, BOLLAR, BOLA trial. And you had to give the hormone therapy at least 2 to 3 years for locally advanced cancer. That also from that trial, BOLA trial. So BOLA trial and pivot trial and protect trial. So all we have to note regards to the different modes of treatment. Yes, sir.
So those trials will show that screening is useful when your life expectancy is long, and radical surgery and radical radiotherapy will have a beneficial effect. There is a long-term follow-up is possible.
So what is the message from Shashikumar study? What is the take-home message?
Yeah, only
It's
thing
like-
is Dr. Shashikumar study is slightly outdated.
Yeah,
And
okay.
he have examined the clinically detected cancer, not the screening detected cancer. And he's not mentioned about whether it's an organ confined cancer or not. Is it what do you mean by early
It is
cancer?
organ. Yeah, in this trial, they only take the patient organ confined. That means they mention localized prostate cancer.
It's actually low risk and intermediate risk.
Low risk.
High
Yeah,
risk
low
is
risk and
excluded.
intermediate.
Yeah.
And what is the disease-specific morbidity? Because the group who underwent the radical prostatectomy, because the prostatectomy have the morbidity, no?
I don't
I
know.
think they are primary.
Exactly the
And the second, this particular study, they only discuss about this primary, their outcome and the secondary outcome
Survival.
include the mortality, prostate cancer
Yeah.
specific and all cause and the distant metastasis.
Yeah.
I don't know
Okay.
whether they analyze the other details.
Yeah.
Regards to-
So in a summary, if you have to sort of talk about radical prostatectomy versus active monitoring, active surveillance, there's one paper which is sort of recommending radical surgery, that is the SPGC4, what we have discussed. And the other two papers, pivot trial and the protect trial, shows there's no significant benefit between the two modalities. So that is something which we have to think.
Yeah, especially if the life expectancy is short, no, Nishanta.
Yes, sir.
If it
Yes.
is more than 20, there may be subtle differences, advantages. So I suppose you all can tell all these three, no? So message is a mixed message, particularly if your life expectancy is going to be less than 20 years. And so if the life expectancy is long, so young people, it may be worth doing some intervention. I don't know. That's how I look at it, because there is no clear message. One proper study, as Aravindan says, I mean, we have to consider the side effects, post-operative mortality, even in inexperienced hands. So when we consider all these things, it's a difficult decision that we can take.
Yeah,
It's
other
an
things that we have
individualized
to-
decision.
Yeah, we have to consider the risk stratification, sir. Whether it's a low risk cancer or intermediate risk cancer or high risk cancer. Of course,
Okay.
high risk cancer definitely you have to do intervention. Again, intermediate risk also nowadays they are dividing low intermediate risk and the high intermediate risk, depending on the Gleason score, whether it's a 3+4 or 4+3. 3+4 is a low intermediate risk. And again, depending on number of cause positive and the PSA level. So when we are answering, we have to say age is a matter and the risk stratification. Low risk, whatever you do, patient will survive. But high risk, you definitely have to go for intervention. Intermediate risk, again, depending on the multiple other factors. So when we are answering, we have to take that the stratification and discuss.
Yeah, one other thing is the paradigm shift of towards active surveillance is actually the data coming from the pivot trial. So there had been a lot of unnecessary or over treatment which has happened and then when they putting out the evidence from the pivot trial, things were changing, and that is also the historical point of view.
Is in Sashikumar's trial, not only the detection is clinically based, even the progression, the clinical progression also detected clinically, like the blood outflow symptoms, DRE findings. So that was the major limitation of that study. The detection and the follow-up or the progression also detected clinically, other than imaging.
Right. Shall we move on to the next one? Is Munipriya ready or how?
Yes, sir. Hillary can share my slides.
Hillary, can you help us?
He already texted, I think.
Or we can see in our phones.
Hillary, are you there?
Hillary also go on, I think.
Okay. Right, then we'll ask Nalin to do his presentation on comparative effectiveness of minimally invasive versus open radical prostatectomy.
Good morning, sir.
Yes,
Can
you can hear, you
yeah.
can see the slides.
Yeah. This study is about comparative effectiveness of minimally invasive versus open radical prostatectomy, and it was published in 2009 and in the Journal of American Medical Association. And this was a population-based observational cohort study. It was covered, they say they were covering about 26% of the US population based on a surveillance epidemiology and end result, that is here Medicare data for analysis. That was a database in which the patient's data is collected with regards to insurance claims. And in that database, they have selected 137,000, more than 137,000 patients who were diagnosed with CA prostate and aged more than 65 years. And out of that, the selection for the study was 8,837 individuals. And out of that, 6,899 patients had undergone open radical prostatectomy, whereas 1,938 had undergone robotic assisted minimally invasive radical prostatectomy. And in this study, they have excluded the patients who have undergone open perineal prostatectomy, as well as people who have had concurrent other cancers as well. So they measured morbidity, mortality, length of hospital stay, and anastomotic strictures, and incontinence and erectile dysfunction, and the requirement for additional cancer therapy during the follow-up period. So they divided the complications into immediate post-operative, that was up to 30 days, and then anastomotic strictures. The complication of anastomotic strictures were analyzed from day 31 to day 365, that is up to 1 year. And the erectile dysfunction and lower tract symptoms were assessed up to 18 months post-operative. And in the initial stage, they have observed that there was demographic as well as tumor characteristics were different in the two groups. So they made a statistical correction in which they used weighted propensity score method to adjust these differences. And with that, they have manipulated the data so that the characteristics were similar in both the groups. But later on, they have compared the raw data as well with regards to the two groups. So there are two analyses. One is the adjusted outcomes as well as non-adjusted outcomes in the study. And the final results in both the groups, that is adjusted data as well as non-adjusted data, were equal almost. So with that, they got the results at that minimally invasive radical prostatectomy group had a shorter length of hospital stay compared to the open radical prostatectomy. That was a 1 day difference. And they had a significantly less incidence of post-operative blood transfusions. That was 2.7% in the MIRP group compared to 20% in the radical prostatectomy group. And in the MIRP group, the post-operative respiratory complications were also comparatively less, that is 4.3% compared to 6.6% in the open radical prostatectomy group. And interestingly, short-term anastomotic stricture rates were less in MIRP, that is minimally invasive radical prostatectomy group. That was 5.8%. But it was 14% in the open radical prostatectomy group. And on the other hand, the minimally invasive prostatectomy group had more lower urinary tract complications post-operatively compared to the open radical prostatectomy group. And incontinence rates were higher in the minimally invasive radical prostatectomy group. That was 15.9% years compared to 12.2% years in the open radical prostatectomy group. And erectile dysfunction was also reported more in the minimally invasive group. That was 26.8% years. And with regards to requirement for additional cancer treatment, that is a surrogate indicator of the clearance of cancer, both groups had similar results. In other words, with regards to cancer treatment, both the groups had a similar outcome. And they have shown that with regards to demographic data, Black and Hispanic patients were less likely to receive minimally invasive retropubic prostatectomy compared to white and Asians, probably because of the socioeconomic background and the cost associated with the high cost associated with the minimally invasive robotic assisted radical prostatectomy. And as you have seen that lower urinary tract symptoms and erectile dysfunction complications and incontinence complications were reported higher in the minimally invasive group. That is probably due to the higher complaints or higher rates of reporting the complications post-operatively. But they have specifically looked into whether they have undergone additional procedures for incontinence. In both the groups, the rates of additional procedures for incontinence were similar. But the complaints with regards to incontinence and GU complications were higher in minimally invasive radical prostate group. That is probably due to the higher reporting and the higher expectations of people who are coming from a higher socioeconomic background who have undergone minimally invasive prostatectomy. That was the conclusion. And with regards to the limitation of the study, these data were totally taken from a billing database, but not clinical data, but they have gone through all the records to retrieve as much as possible clinical data. But the base database was a billing data database. And the study had gone for about 4 years, but compared to the prostate cancer, life expectancy and prostate cancer progression, it was a comparatively shorter period. So the inferences may not show the exact long-term effects of minimally invasive versus radical prostatectomy. And as I said earlier, the erectile dysfunction and incontinence rates that were reported will be of observer bias. That's all. Thank you.
Thank you, Nal. Any comments?
Just to integrate with the other knowledge, Nalin, what is the incidence of erectile dysfunction and incontinence usually after the prostatectomy?
It's around generally around 2% to less than 5%. But in this study, the open radical prostatectomy group had a 2.1% erectile dysfunction rate compared to 2.8%.
I'm talking about immediately post-op, the incident of, I think the paper is talking about the long-term.
Long-term, sir.
Yeah. Usually soon after the surgery, what percentage will have erectile dysfunction and incontinence? I think the 50%. 50% will have ED and 50% will have incontinence. That's a transient incontinence.
Yeah.
The standard figure for a long-term incontinence is 5%. Maybe it's less after the robotic surgeries. As you said, it's around 2%. But it's a definition of the incontinence after the radical prostatectomy. Because it's a political definition. That's why I'm asking. The definition is, they say, requiring more than 1 pad per day. So that means really is a kind of incontinence, isn't it? So that is.
So do they give a time period as at which time we should assess that?
Beyond 6 months. Beyond 6 months. Requiring more than 1 pads per day affects only the 5% of the patient beyond 6 months due to the external urethral sphincter injury. So the standard value is transient is 50%, long term is 5%, but the number is getting less and less with the robotic surgery. Another question is, during the radical prostatectomy, the positive margins are common in apex or base or the posterolateral aspect, especially in the open surgery I'm talking.
I think it's in the apex because we are trying to preserve the sphincter as much as possible. So there is a compromisation.
Yeah, we of course don't do the perineal approach. If we do the perineal approach, the positive margins are common in which part?
That should be in the bladder base.
Yeah, base of the prostate. Yeah.
Okay, thank you.
We'll
move to the next paper. Dr. Achyutan will do the quality of life and satisfaction with outcome from prostate cancer survivors.
Can you see my slide? Good morning.
Yes.
Yeah.
Here can.
So I'll be talking about quality of life and satisfaction with the outcome following in prostate cancer survivors after treatment for localized prostate cancer. This was a research published in New England Journal of Medicine. So they wanted to see how was the outcome related to the certain factors and whether the patient was completely the overall satisfaction after the procedure did it have any relation to the factors, certain factors, and whether the partner's satisfaction with the procedure has also bearing with the various factors and the quality of life domains after the surgery. So this was a US-based multi-center study, prospective study over the period of 3 years. Patients were men with the staging of T1 to T2 prostate cancer, the procedure was electively selected by the patient. So they were not randomized. They underwent prostatectomy, brachytherapy, or radiotherapy. So there was a total number of 1,200 patients and 625 partners. So the material that was used to assess was patient reported outcomes. They use an expanded prostate cancer index composite and the service satisfaction scale for cancer. This was patient gave the outcome before procedure, 2 months after the procedure, 6 months after the procedure, and 1 year and 2 years after the procedure. There were similar questionnaires to be reported by the partners as well. The median follow-up was over the period of 30 months. So if you just divide the treatment options taken up by the patients, brachytherapy was solely preferred by 271. 35 received brachytherapy with the combination of either external beam radiotherapy and androgen suppression therapy or both. Radiotherapy was opted by 202 patients, radical prostatectomy by 561 patients. And another 41 preferred underwent non-nerve sparing radical prostatectomy. So the domains assessed in the research were sexual function, bowel function, urinary incontinence, and urinary irritation and other symptoms, and also overall vitality and other outcomes, endocrine-based outcomes. So if I go to sexual function, generally in all the options the patients went through, significant the sexual quality was significantly affected. These findings are also correlated with the opinions from the partners as well. If you consider prostatectomy, nerve-sparing procedure gave a less, had a less bearing on the sexual function after the procedure. And when you consider radiotherapy and brachytherapy, they had worse sexual function after procedure when it was combined with androgen suppression therapy. So they have considered certain factors which showed clear bad sexual function after surgery. Those factors were older age, larger size of the prostate, high PSA value before the procedure. These were correlated with higher, lower post-procedure sexual function. If you consider erectile dysfunction, higher percentage was in prostatectomy group as expected, and less in the radiotherapy group, in the brachytherapy group. Sorry. Incontinence was higher in at the period of worse at the period of 2 months, but gradually improved in patients with the prostatectomy. Worse incontinence was associated with the older age, the black race, and high PSA at diagnosis. If you consider radiotherapy and brachytherapy, they were associated with the other urinary irritative symptoms, which worsened, resolved at the period of 1 year, and gradually improved over the baseline, initial pre-procedure, pre-treatment value over the period of 2 years. Then, if you consider irritative symptoms, the urinary irritative symptoms, they were relieved after surgery in patients with a larger prostate. And this research also shows the urinary symptoms affecting the patient also had a significant bearing on the partners as well. To consider bowel function, radical prostatectomy did not have a significant bearing on bowel function, but brachytherapy and radiotherapy had a significant effect on the bowel function, especially early after the treatment. And it lasted for more than 1 year. General endocrine assessment and endocrine-based side effects and vitality was worse in radiotherapy and brachytherapy when combined with the hormonal treatment and androgen depression therapy. The factors which were correlating with the more significant effect on the vitality were obesity, hormone therapy, and the prostate size, which gave the worst scores in vitality and hormonal function. And these also had a very significant, to consider other factors, up to 20%, 19% spouses also complained about vitality and endocrine related side effects. So the overall outcome satisfaction in the descending priority correlated significantly with the sexual function, vitality, and urinary function post-procedure. These findings were also correlated with the opinion of the partners as well. The limitations of this trial, so there was no randomization of the patients. The patients were allowed to choose their option. The follow-up period was only 2 years, so there might be significant difference if there was long-term follow-up. And in the study population, Black patients significantly reported a less favorable outcomes generally. So they it was not assessed whether this was due to biological reasons or disparity in the treatment that was not assessed in the study. So in conclusion, if you take the quality of life domains, all 5 domains, which are urinary incontinence, bowel function, general vitality and endocrine function, and they had very different, they were differently affected by each option available for localized prostate cancer treatment. And these have significantly affected the satisfaction of the outcome of the patient and also their spouses. Thank you.
Thank you, Arju.
Yeah.
Any comments? So you all will have to remember the percentages Balagobi said, no? 5%
yes,
at 6 months and 50% immediately after.
And also, sir,
Incontinence is, yeah?
erection rehabilitation, how to do.
Yes.
After the surgery, they will ask, and
That's
they will
right.
ask about sildenafil and things.
Yes.
And also they will ask what is the important factor that decide whether there will be a successful rehabilitation with sildenafil is whether we are preserving the nerve or not.
Yes.
So if there's no nerve, the sildenafil won't work.
Yeah.
Because if you know the physiology, the receptors and things, so the nerve sparing must be there. If no nerves are damaged, then it won't work.
Put into figures, return to erection, if it is unilateral nerve sparing, it's like 40% and 80% if it is bilateral sparing.
Okay. So if you can refer those numbers, gives some confidence, no? That's good. That's why you are, yes.
So I can share the.
Actually, even a unilateral nerve sparing is quite beneficial.
Okay, now Muni is ready with his presentation, I think.
Yes, sir.
Please go ahead.
Thank you, Gopi, for sharing my slides.
No problem. Thank you.
Yeah. This is a study of a patient with clinical suspicious prostate cancer who have not undergone prior biopsy. How does MRI with or without targeted biopsy compare to the standard crust biopsy? So whether it is a clinically significant to detect the prostate cancer. This is the study. So it's a multi-center study conducted in 11 countries. The study began in 2016. It is a randomized non-inferiority trial. And so in the study, they were selected 500 patients. So inclusion criteria were men who had not undergone prior biopsy, clinically suspicious prostate cancer based on the elevated PSA level, and abnormal digital rectal examination, or both. So they have excluded PSA greater than 20 nanograms per milliliter, and the digital rectal findings shows the extracapsular disease or inability to undergo prostate biopsy or MRI. So those are the exclusion criteria. So they have randomized into 1-to-1, and in MRI with or without targeted biopsy, they have done the 1.5 Tesla or 3 Tesla MRI. They will go through the T2 weighted or diffuser weight imaging or the contrast enhanced imaging, and they have categorized pyrites categorization, and they were not targeted biopsies, pyrites 1 and 2 group, and they get the targeted biopsy only pyrite 3, 4, and 5 groups. And other arm, the standard biopsy were taken, that is 10 to 12 core biopsy from the peripheral zone. So the endpoints of study, there is a primary outcome as well as the secondary outcome. In primary outcome, the proportion of men with clinically significant prostate cancer, the presence of a single biopsy core, Gleason score 3+4, that is 7 or greater, is the primary outcome. The secondary outcome is proportion of men with clinically insignificant cancer, that is Gleason score 3+3, 6, or proportion of men with MRI targeted biopsy group who did not undergo biopsy. And other thing is the proportion of men with adverse events after the interventions. Those are the things. So results, the mean age of study group is 64, and median PSA level is 6.6 nanogram per milliliter. The other findings, and clinically significant cancer was detected in 95 men, that is 38% in MRI targeted biopsy group, compared to the 26%, that is 64 in standard biopsy group. So absolute risk reduction is 12 in this cohort, and the diagnosis of clinically insignificant cancer was made 9% men versus 22% men in MRI. The MRI versus standard biopsy respectively. A total of 2% of patients in either group experience serious adverse events. So common patient-reported events such as blood in urine, blood in urine, rectal bleeding, and the those things compared to the targeted biopsy, standard biopsy, much more significant amount found. And summary of this study, they could 28% of patients could avoid the biopsy during this study, and so they can prevent overtreatment by reducing the detection of clinically insignificant prostate cancer, as well as increase the detection of clinically significant prostate cancer. So finally, the study provides high quality evidence to support use of multiparametric MRI in men with an elective elevated PSA as a triage test for determining of the biopsy, whether the patient go for a biopsy or not. So because of that, it has spared widespread adoption of this image modality now worldwide. That is the precision trial.
Thank you, Moni.
Yeah, Moni, this is, if you see the co-author, sorry, the main principal investigator is Viru Kasi Viswanathan. He is a Sri Lankan. He's actually a registrar, urology registrar, working in the UCL, University College of London. And he has done so many research in regards to the prostate biopsy. And so it's basically multiparametric MRI followed by targeted biopsy versus a standard trust biopsy. You said multi-parametric MRI. What do you understand by multi-parametric MRI, Priya?
In multiparametric MRI, they have used the rectal coil and
what do you mean by, you mentioned that multiple parameters, multi-parametric. So you said they do T1 and T2.
Yeah.
That is for anatomical information.
Right.
What they see in a T1 is any hemorrhage or any bone problem or any lymph node problem. T1. T1, we won't see the cancer. T2, to see the cancer that you will see in a peripheral zone, hypo-intense. That's mean a black color lesion in the peripheral zone. Usually peripheral zone will be white in the T2 because more water. So T1 is T2 for anatomical information. Then there's two things for functional information. One is diffusion weighted image, DWI, diffusion weighted image. So there are two things. One is ADC map, other one is long B value. So in ADC map also, cancer will look black color. But in the long B value, the cancer will look white, bright color. So plus or minus, you can do a dynamic contrast enhancement, DCE. So gadolinium you can use. So these two, diffusion weighted image plus the contrast enhancement, DCE, give the functional information about the cancer. T1 and T2 give the anatomical information. So we are using the 4 parameters. That's why it's known as, at least you have to use the 3 parameters. Using the contrast, nowadays they are questioning whether it's giving any additional information. So at least you have to use the 3 parameters. That's why it's known as a multi-parametric MRI. It's a standard for the prostate cancer. And they have defined the clinically significant cancer. It's Gleason score 3+4 or more, and also the maximum cancer length, MCL, more than 6 millimeter or more. So the finding is increase the detection of a clinical significant cancer, and is reduce the detection of the clinically insignificant cancer, that is Gleason 6 cancer. So basically they said doing a multi-parametric MRI before and doing a biopsy is better than just going for a standard trust biopsy. And one more question, Manipriya, if you do a trust biopsy, what are the lesions you can miss when compared to the standard, the precision biopsy, or we use the perineal biopsy, transperineal biopsy. If we do a trust biopsy, which lesions we can miss in the biopsy? One is the anterior cancer, like if you have a cancer in the anterior fibromuscular stroma or the glands, so those we can miss because we have to pierce the urethra and go to the other side. So we usually just target on the peripheral zone. That cancer we can miss. So we know that 20% of the cancers occurs in anteriorly. Only 80% of the cancer occurs in the peripheral zone. So we can miss that cancer. Now also the apical cancer. So when you're doing a trust biopsy, if there's a lesion in the apex, we can miss. So those are picked up in the standard our perineal biopsy, TP biopsy, transperineal biopsy.
So with the with the transperineal biopsy, so we can minimize these errors compared to the standard biopsy.
Yes, definitely. That's why the transperineal biopsy is better. Of course, we do more course 24, but there's a slightly more risk of urinary retention, but the sepsis is minimum when compared to the trust biopsy because we are not going through the rectum. So that's the advantage of the TP biopsy.
We talked about this maximum cancer core length. None of the guidelines talk about this significance of MCCL, like to decide treatment. But each and every MDT we talk about MCCL. What is your opinion?
the maximum cancer length. Taha?
Yeah, maximum cancer core length. So is it going to decide
That of
our
course,
treatment?
that is of course immaterial in high risk cancer. It is only important when you are deciding, there is a active, up to now, we go for active surveillance only in the low risk cancer. But now the NICE guidelines have extended the active surveillance protocol even for a low intermediate risk cancer, like, Gleason 3+4 with a core length is minimal, only one core was positive, core length is minimum, then we can go for a active surveillance. That is known as extended active surveillance protocol. That is given in the NICE guidelines also. If you say Gleason 3+4, you are going to go for active surveillance, that is wrong. But there's a low risk, low intermediate risk cancer, like only one core was positive, and the cancer length is minimum, less than 5 millimeter, then we can go for active surveillance. For that decision, the cancer length is, maximum cancer length is important. But if a high risk cancer, whatever the length, we have to go for a active treatment. Of course, low risk cancer, we go for a low risk interventions. Taha, I hope I have.
Yeah, they're talking about favorable and unfavorable intermediate risk, no? That's the, all right, thank you.
The favorable and unfavorable mainly given by the grade grouping. But as Gobi said, the other important factor is the core length and the disease burden.
And the percentage of course, right, 50%.
And regarding this endorectal coil, it is not a mandatory thing. What they said is if you have the coil, that will give a better local staging. But most of these pilots are defined with just without the coil. So this coil is not a must. And other practical importance is if you given a MRI film to see whether this is a T1 or a T2, you can always see the bladder. And if the bladder has, if the urine is bright, it is usually T2. If the urine is dark, it is T1.
Yeah, I think they might give a MRI. So we have to know the basics. They will give a clear, very simple MRI of the peripheral zone with the small lesion. So basic interpretation and knowing this T1, T2, DC is, I think, important. And anyone discussing about the PROMISE trial? That's again an important trial. So that have said, doing a multiparametric before the biopsy, reduce the unnecessary biopsy by 27%, increase the clinically significant cancer detection by nearly 20%, and it's reduce the diagnosis of clinically insignificant cancer. So similar thing, PROMISE trial. Yeah, but there's one more trial that is totally opposite of the PROMISE trial. That is known as ASSIST trial, ASIST, ASSIST trial. Why? If you see the EAU guideline, they are not always recommending to do a multiparametric MRI before the biopsy. Maybe, I don't know if they have changed last year. So till 2020-21, they are a bit reluctant to say a strong recommendation to do a MRI before the biopsy because they don't have the facility to do a MRI for all the patients and recommending that as a strong recommendation. But in the UK, no one will do a biopsy without MRI. So it's a strong, NICE guideline, strong recommendation. You do a MRI before the biopsy based on the PROTECT trial and the precision trial and the PROMISE trial. So, but there's ASSIST trial. I think came from European Union countries. They said, totally opposite of the PROMISE trial. There's no change. But I think the PROMISE and the precision trials are more standard now.
So all this is if the PSA is less than 20, Balagop, is it?
Exclusion criteria, yes, sir. More than 20, of course, is going into the high risk.
Yeah.
So whatever the biopsy you do, it will be positive.
No? Yeah. Because this study has clinically malignant ones also. That is why I was just thinking. Okay, thank you very much.
Yeah, I have a small question, Balagopi.
Yes.
Yeah, the Muniprians group, the study, there's a group, Pyrad 1 and 2. They didn't have the biopsy, but they had an abnormal DRE and elevated PSA.
Yeah,
So
so
what
it's a
we
very
can
good thing. Yeah. So I want to update that one as well. So when you will say positive MRI is Pirates 3 or more, it's the definition of positive MRI. If you get a positive MRI, you had to do a both systematic biopsy plus targeted biopsy. What I mean by systematic biopsy is covering all the areas. Targeted biopsy is if MRI say there's a lesion, you take the targeted biopsy. So if there's a positive MRI, that's mean the Pirates 3 or more, you have to do both systematic biopsy and the targeted biopsy. Now, if a MRI say Pilot score 2 or less, then you have to see the clinical suspicion is more high or low. If a clinical suspicion is low, you can omit the biopsy, but you have to take a shared decision making with the patient. You have to tell this to the patient, and you also tell the input, and you have to tell still we can miss the cancer, but clinically you have a lower risk. So that is a shared decision. That word must you have to explain in the exam. Shared decision. If there is the cancer risk is low, with the Pirates is 1 or 2. If a cancer risk is high, your DR is abnormal, you think PSA is high, then of course you have to proceed with the biopsy.
So
I
standard
hope I have answered. Yeah.
Yeah. Thanks.
Gobi,
Yes.
in PROMISE trial, as I remember, there is a small, the 2% of prostate cancer can miss. So according to that, this Pirates 1 and 2 group is in that category, no?
Maybe possible, yeah. So that we have to tell this imaging does not, just because Pirates 1 or 2 is not exclude the cancer.
Yeah.
Only thing will exclude is even biopsy won't exclude. Still, then again I have to tell you, Pirates 4, you do a biopsy is negative, but clinically you think there's a cancer. What do you do? That they can ask that question.
So we can go for a second biopsy after informing the patient.
Second biopsy is a systematic biopsy or target biopsy?
Target biopsy.
Only target biopsy. That's the answer. So you do a systematic biopsy plus target biopsy. You miss the cancer. If you still think cancer, go for a second target biopsy. So target the lesion of the lesion and do the biopsy. Yes.
What's the time interval, Balagopi? Is it 3 months like?
Why we have to wait? If a patient recovered fully and it's not going to change anything. So recovered fully, maybe we can, I don't know the exact time, but yeah, we can do after maybe 6 weeks. I don't know. It's not mentioned.
When they talk about the artifact, bleeding.
No, we are not going for a MRI. We are going for only biopsy, no re-MRI.
Just a biopsy. All right. Okay. Okay.
Thank you.
And
Puni, you can go to the next paper.
Yes,
sir. Evidence for this fusion biopsy that we have to mention here?
Yeah, Dr. Nishant, can you explain what are the different types of biopsies available? Then people will understand what is the difference between cognition biopsy, fusion biopsy, and all this.
I have a very less knowledge on that because I haven't seen that. But as far as I'm aware, you can actually combine the MRI findings into a ultrasonic device where you can do a real-time MRI images which overlaps with your ultrasound imaging, and this happens in real time, and it will exactly localize where your lesion is, and it will sort of real-time manner will show you where your needle is. So you can precisely take, and there is a concept called concordance. What is given in the MRI, whether we have biopsied that. So whether we have achieved the target. So that is what is meant by the MRI fusion biopsy, and enlighten us on cognition biopsy.
Yeah. So when you say target biopsy, you're obviously you are going to take few cores from the target. So how many cores you will take? That's the other question they will ask.
4 cores. We have to take
2 to 4
3 or
cores.
4.
2 to 4 cores. That's from the target. If they say saturation biopsy, what is the meaning of saturation biopsy? How many cores?
6 cores.
24
24.
or more. That's the meaning of saturation biopsy.
If the prostate is bigger, it will be more, isn't it?
Yeah, more. So saturation biopsy is a lot of biopsies saturating the prostate. Target biopsy, some centers do 2, some centers do 4, 2 to 4. Now, so doing a biopsy worldwide, 2 methods. One is doing a biopsy after MRI, that's the standard. The countries like us, we do a biopsy before the image. So 2 methods. Now, if you are doing after the MRI scan, there are 3 types. One is a cognitive biopsy. That's mean you before the biopsy, you see the screen, you see the left peripheral zone, there is a lesion. So you think in your mind and you direct the needle in that direction and take a more biopsy from that area. And also you take a saturation biopsy. That is known as cognition biopsy. As Dr. Nishant said, the fusion biopsy is there's a software. So you load the MR image to the screen, and then you load your trust biopsy probe image also. Then both will synchronize, and then you will take a biopsy from that area. Is known as a fusion biopsy. Now it's based on the software. Again, the fusion biopsy, there are 2 types. One is rigid fusion, elastic fusion. Rigid fusion mean you have stored the images, but with the movement of your transrectal probe, the image won't change. But of course, when you press with the truss probe, the lesion may move here and there. So the elastic fusion is more sensitive than the rigid fusion. So there are 2 types. That is not, of course, important. So one is a cognitive biopsy. Second one is the fusion biopsy. Third one is the MRI bow biopsy. That's mean they do the biopsy in an MRI room. All the instrument must be MRI compatible. Even our biopsy needle and everything is compatible. So they do MRI. Under direction of MRI, they do the biopsy. That is very expensive. Only few centers do that. That is known as MRI bow biopsy, B-O-R-E, bow biopsy. So 3 biopsy they do after the MRI. One is the cognition biopsy. That's the commonly done one. Next one is a fusion biopsy, expensive, slightly, software. Third one is more expensive, it's the MRI bow biopsy. But if you see the cancer detection rate, cognition biopsy 86, fusion biopsy 88.8, bow biopsy 92. More or less, it's 90%. So no significant difference what you are doing. Maybe slightly increased, but no different. So these are the 3 biopsy after the MRI. Yeah, terminology.
Thank you, Gopi. Thank you very much.
Thank you.
Shall we go to the next one, Muni?
Yes, sir. Gopi, can you move the slides to next one? Slide number 4. Yes. Hello. This is can you hear, sir?
Yes.
Right. This is a study, the clinical results of long-term follow-up of large active surveillance cohort with localized prostate cancer. This a study done in Toronto, Canada in 1995. It is a prospective single-arm cohort study which was published in 2010 in Journal of Clinical Oncology. their research question was in patient with clinically localized favorable risk prostate cancer, that is Gleason score 6 or less, PSA 10 or less. What are the outcomes of active surveillance? They want to find the favorable risk prostate cancer, that is Gleason 6 or less, PSA 10 or less. And in first 4 years of the study, the men older than 70 years with PSA up to 15 nanograms per liter or Gleason score up to 3+4 were also included. Exclusion criteria: men with clinically advanced prostate cancer and or those who intermediate or high risk disease. Then followed with active surveillance, periodic PSA testing and the repeat biopsies were performed. PSA testing initial 2 years, they have done every 3 monthly PSA test. After that, every 6 monthly. And 8 to 14 for confirmatory biopsy at 6 to 12 months. The post diagnosis were taken, and then every 3 to 4 years reclassified. And the clinical progression, development of palpable nodule that was subsequent investigated with biopsy and histological upgrade were performed. Other important thing is PSA doubling time. If it is a doubling time less than 2 years, was used to trigger for radical treatment during the first 4 years of the study. But later on, they have changed to 3 years until 2009, from which it did not act the trigger and instead was used an indicator for further investigation for with biopsy or MRI, multiparametric MRI. So this study is followed up 6.8 years. The endpoint was overall survival, cause-specific survival, time to stopping active surveillance, and time to PSA fail. So results, the median age is 70.3 and 83% was Gleason score 6 or less disease. 97 of patient, that is 21%, died during the follow-up. Only 3, that is 0.6%, cause other than the prostate cancer. 135 patients, that is around 30%, stop active surveillance. The main reason were short PSA doubling time, that is 14%, 4%, and the Gleason score upgrading progression is 8%. Patient preference is another 4%. So overall, the active surveillance was stopped in 30%, and that is due to PSA doubling, less PSA doubling time 14%, Gleason score grade progression 8%, and the patient preference 4%. In summary, this study established the favorable outcomes of active surveillance as management strategy for men with low-risk prostate cancer. As long as patients were carefully monitored, local treatment with the curative intent can be safely deferred long-term in men with many patients. So that is their outcome. That's it. Thank you.
Thank you. questions or comments?
So overall, cancer specific survival was more than 90%, isn't it?
Yeah, more than 99. No?
More than 99, yeah. I think
Yes.
when you recommend active surveillance, this paper, this is called CLOTS trial, and the other one is the PROTECT trial that we have to produce as the available evidence.
Yes. And the results are so good. That's why now it is the active extended group is also included. No, Nishant, as Gopi says, 3+4 also.
Yeah, more or less they are like when you talk about the risk category, they are like favorable risk and vice prostate cancer.
Yes.
Yeah, if you are doing the active surveillance protocol, so what is the next step? So you are managing a young patient with active surveillance. How we are going to follow up him? Dr. Munipriya or anyone?
Number one, we have to decide the criteria. I mean, who we are going to offer active surveillance. That is like Royal Marsden criteria and the follow-up protocol. Those are the two things we have to consider.
Yeah. So what is the recommendation now? The EAU.
Like
DRE annually and PSA 3 monthly for first year and 6 monthly for subsequent years. And just to see the PSA kinetics. Initially, there was a repeat biopsy at 1 year, trust biopsy, which was now replaced with a repeat MRI at first year follow-up, post of first year follow-up, and then do MRI or trust targeted biopsy if there are any difference or clinically indicated.
Yeah. So 3 monthly PSA, 6 monthly DRE, at 1 year MRI plus or minus biopsies, depending on your clinical judgment. Your PSA is, or you are worried about it, high risk patient, family history, then better to go for a biopsy. But NICE previously said to a biopsy at 1 year. Now they have changed to a MRI at 1 year. And if you think any progression or change in the MRI, go for a biopsy. So 3 monthly PSA, 6 monthly DRE, 1 year MRI plus or minus biopsy.
Thank you. So the last paper is also by Taha because Nishant is unable to attend the meeting. So I invite Taha to do the presentation.
Yes. I think Gobi should switch off sharing, I think.
Gobi will have to remove these slides. Right. Okay, can see the slides now.
Okay, sir. This is the paper of adjuvant radiotherapy for pathological T3 and node organ confined disease. The Southwest Oncology Group 8794 trial. The research question was, in patient with PT3 and node M node prostate cancer, does adjuvant radiotherapy improve metastatic pre-survival? So methodology, 425 patients with PT3 and node M node randomized to 60 to 64 gray in 30 to 32 fraction adjuvant radiotherapy versus observation. These are the included patient criteria: extracapsular tumor extension or seminal vesicle invasion or positive surgical margin. If there's a presence of pelvic lymph node or those with surgical complication post-operatively, such as rectal injury, total urinary incontinence, or pelvic infection, were excluded. The endpoints were metastatic free survival and death due to any causes. The median follow-up was 10.6 years. Results, randomization like roughly 1:1, 211 for observation and 214 for radiotherapy. 70 patients under observation needed radiotherapy ultimately. About half of the patient had preoperative PSA more than 10. Results continues. We can see that metastatic free survival is better in adjuvant radiotherapy group, that is 35% compared to 43% in observation group. And again, biochemical progression, they have taken PSA more than 0.4, but biochemical recurrence now after radical prostatectomy we call like more than 0.2. Adjuvant radiotherapy group, it's 35% compared to observation group 64%. Recurrent-free survival also better in the radiotherapy group, 39% compared to 52%. Importantly, overall survival also better, 13% compared to 39%. So conclusion with that study, adjuvant radiotherapy after radical prostatectomy for men with PT3, N-node, M-node prostate cancer significantly reduces metastatic free survival and increases overall survival. Sorry, reduces metastasis or increases metastatic free survival and increases overall survival. With that, it's about EAU guideline on, they say only offer adjuvant image modulated radiotherapy or intensity modulated radiotherapy or image guided radiotherapy to high risk patients with at least 2 out of 3 high risk features. That's a strong recommendation. These are the high risk features: grade 4 or 5, PT3, or positive margin. That was the study, sir.
Okay, thank you. So that's a good conclusion. Now that we should know.
That is the another study that Gobi was talking about. Bola et al. Study. That's the immediate radiotherapy or delayed radiotherapy. That also support this adjuvant radiotherapy after radical prostatectomy. They have compared immediate as well as delayed radiotherapy. But in delayed group, biological free survival in 5 years. In immediate group 72% compared to 51% in delayed radiotherapy.
Right.
So
better to give early radiotherapy.
Yes, sir.
Thank you. Any questions?
Taha, these all are what type of external beam radiotherapy? Is it conventional? Or is it 3D conformal? Or is it IMRT? Or is it VMAT? I'm just asking because people might ask what are the different types of radiotherapies are available. Now we know that we use the previously used one in Maharagama is just a conventional one, isn't it? Just rectangular, opposite side rectangular things give the radiation that have a more side effects. Then we get the 3D conformal where they feed the CT images and give non-rectangular fields of radiation. That is a 3D conformal. But if you see in Silingo and all, they have because the 3D informal also will change with the real time when the patient movements. So that is they have, I think, is IMRT, that is intensity modulated. That's a real time movements also. It changed, the field changed. So good for the patient. The latest one is VMAT, that is a volumetric modulated external beam radiotherapy. The advantage is usually in conventional radiotherapy, we can give only 2 grays, 1.5 to 2 grays per session. That's mean if you are giving 70 gray total or 74 gray total, that's the standard for prostate cancer, patient have to go 37 times. So that's mean about 7 weeks or 8 weeks, except the weekends they give off. Now, when you go for a VMAT and IMRT, you can give more grays per session, up to the 4 grays. So then what will happen is number of session is less, patients are happy. That's the advantage of going for a better radiotherapy. I think a little bit about this these terminologies we have to know.
Yeah.
Thank you.
Thank you very much. Any other questions?
What do you mean by 3D conformal, Gobi?
3D conformal is they feed the CT images. Then they get the where is a prostate, but size of prostate, and target the prostate. But if a patient change the position and things, it won't change. It's better than our conventional radiotherapy, but still it can attack the rectum, it can attack the bladder, so they can develop bladder symptoms and rectal symptoms. The next one is IMRT. When the patient change also, prostate change the position, radiation also change the direction. So intensity modulator. That's a real time change. Then a volumetric VMRT, I don't know what's the additional advantage. You can give a higher dose per session, so less side effects. I think what is in the Silingo must be IMRT.
Yes, they have IMRT.
Yeah, but the ancient one was in the Maharagama was cobalt one. That's it's a more side effect. So
yes, then they have the linear accelerator and 3D conformal, I think now.
Yeah.
Any other questions, comments?
So, Milan, so this is regarding multiparametric MRI. So in the new version of the PIRAT specification, that means the 2.1 classification, they have given less weight on the dynamic contrast imaging, and they talks about the biparametric MRI. So
yeah, so I was talking about this, Milan. So there are 4 things. One is T1 and T2. Actually, T2 is more important than T1. That is anatomy. Then functional, diffusion weighted imaging, and DCE, the contrast enhancement. Contrast enhancement is less important. Even they were discussing in 2019 and 20 whether giving more gadolinium and things, whether any benefits. So they were planning to remove that from the guidelines. So maybe that has happened now. Now they have the next version of the PIRATs. So they were planning to change that in 2021. So that may be not including the contrast enhancement. Yeah, you are right.
Any other questions? So shall you have our next one on next Friday? Because some people may not have been able to join today because being a Saturday. So rather than having on the same day, it will be better and fair if we keep on changing the day, isn't it? Is it okay, or any other time that you would suggest after the Uromet, or we can, whatever you are liking, we can fix. To me, it doesn't matter.
Yeah, after Uromet,
Friday is a bit of a traveling day for most of the people.
All right. Okay. Shall we make it Thursday then?
Any other weekday? Yeah.
Yeah. Shall we make it Thursday, Nishanta, then?
Yeah.
Good, sir.
Everybody's preference, it's okay,
Yeah.
sir. Many of us, some of us have commitments, but that's okay. Majority.
Yeah, because otherwise it may look little unfair, no, Nishanta?
Yes, sir. Yes.
Yeah. I mean, the same day we will try to record and send the recording.
Yeah, fortunately, we managed to get the recording at the last moment, and after we can get it.
Yeah, this is the thing we are learning now. It started, I think, better than expected, Nishanta. Whatever it is, we managed to cover.
Yeah,
a lot of discussion, learned a lot. without much of a trouble. Everyone has prepared well, and so it's good. We are improving.
So
So
what
we'll
would be
keep
the
on.
advice on slide preparing? Say, I mean, end of the day, we will be having, better to have like, concise slides, like 3 slides per
Yeah,
study.
it's good. No, I think, I don't know. I am, of course, quite happy. Very
I
brief
think
and precise.
at the end of the thing, like a bit of a learning points or take home message, one single slide
Yeah.
of the particular study would be a very good recap.
Yeah. Taking into consideration other studies as well, no? Because some of these studies may be little too old. If we can select better next 10 papers, I think that will be better. If possible, if he can send it, but not fair to ask too many things for him also.
Yeah. Okay.
But we'll see how it goes. Then we'll tentatively fix it for next Thursday. 10 o'clock, is it okay? Or, I mean,
Okay, sir.
yeah, Wednesday is a holiday, so Thursday will be better. Any other comments, suggestions? Please let us know.
I have a small question.
Yes.
Metastatic prostate cancer, treating the primary, are there any, I couldn't look at the guidelines. Are there any recommendation in the guidelines?
Yes.
Or Gobi?
Yes. So that is the latest things. So if there is a patient having low volume disease, that is by chartered criteria. What is chartered criteria? We will have to see. According to chartered criteria, what is high volume disease is 4 or more bone lesions. And out of that, at least one outside the pelvis or spine, plus or minus visceral lesion. So if someone have 4 more bone lesions, that is known as high volume disease. But if someone have a low volume disease with the metastasis, then you have to give radiotherapy to the prostate. So these will come in our all these other trials, like latitude trial, charter trial. So we can discuss those things. And if you see the Stampede trial, so but there are more to discuss. Dr. Nishant, we can discuss those 3. That's important. Chartered, latitude, and Stampede trial. All 3 discuss about this. Even some centers do a prostatectomy for metastasis. That is to extent, but definitely radiotherapy for the low volume cancer have a survival benefit. That's discussed in the chartered and latitude and Stampede trial. So one person can compare and contrast those 3 trials. Those are landmark trials.
Okay. Thank you. Then shall we end the session?
Yes, sir. Yes, sir. Thank you, sir.
Once again, thank you very much for Gobi and Munipriya and all the presenters who did a wonderful presentation. And of course, the participants who joined and encouraged us. So we'll meet again on Thursday at 10 o'clock. The recorded ones we'll try to send to those who couldn't make it. Thank you very much. Good day.
Thank you, sir.
Thank you very much, sir and Balagobi.
Thank you.
Thank you.
Thank you, sir.
Thank you.